Hi everyone. So for this week, we're going to be covering chapters 12 through 13, which is on intellectual disabilities, autism spectrum disorder, and schizophrenia. So we're going to start by covering chapter 12, which is on intellectual disabilities, and then we'll move on to chapter 13 and spend most of the time talking about autism spectrum disorder, but we'll also talk a little bit about schizophrenia, specifically childhood and adolescent onset, since your book also covers that in that section. Okay, so let's start with chapter 12, intellectual disabilities. Before we talk about intellectual disabilities broadly and the specific disorders within this classification within the DSM, I also want to orient you to where we are in the DSM when we're talking about these particular disorders. So remember, the DSM is our Diagnostic Statistical Manual of Mental Health Disorders, and the way it's organized is Section 1 is sort of just like basic information and gives some caveats about how to use the DSM and the limitations in terms of forensic use. So that's just informational. Then we have Section 2, which is the largest section of the DSM, and this is where all of the diagnostic criteria for each disorder that exists in the DSM is housed. And the way that these diagnoses are presented in the DSM is by sections. So each section represents a cluster of disorders that are theoretically alike, whether there are the same etiological roots, whether the symptoms are like manifest in the same ways. So there's a reason that these disorders are presented in the way that they are in terms of where they fall in the DSM. So when we talk about intellectual disabilities, this is a subset of disorders that falls within the larger section or chapter called the neurodevelopmental disorders chapter. So in the neurodevelopmental disorders section of the DSM, we have intellectual disabilities, which then falls into 3 specific disorders. We have communication disorders, and then those set of disorders that correspond under communication disorders. Then we have autism spectrum disorder, we have ADHD, and then we have the other specified and unspecified types under ADHD. We have specific learning disorder, we have motor disorders, and then we have other neurodevelopmental disorders. So last week, in week 6, we actually covered communication disorders. So we talked about language disorder, we talked about social pragmatic or communication disorder. So I don't think we talked about all of these in depth, but this was the section we covered last week. We also covered specific learning disorder. So remember, these still fall within neurodevelopmental disorders, but these are specifically communication and specific learning disorders. Then the week before, we covered the ADHD section, so attention deficit / hyperactivity disorder. So again, this still falls within neurodevelopmental disorders. So finally, this week, we are covering intellectual disabilities, which contains intellectual disability or intellectual developmental disorder, global developmental delay, and unspecified intellectual disability. We'll also cover autism spectrum disorder, and within this section is just ASD. You'll notice that in the neurodevelopmental section, we have motor disorders. So this includes things like tic, Tourette's, provisional tic disorder. So we are not covering that in this course, but I just want to point out that that is there in the DSM within the neurodevelopmental disorders. Okay, so let's talk about what neurodevelopmental disorders broadly tap into. So these are a group of disorders with onset during the developmental period, and these are things that typically manifest in early childhood. So this is the particular developmental phase where we tend to see symptoms onset. These disorders are characterized by developmental deficits or differences in brain processes that lead to impairment in functioning across settings. And these impairments can range from very specific to very broad. So again, what falls under neurodevelopmental disorders includes intellectual disabilities, communication disorders, autism, ADHD, specific learning disorder, motor disorders, and other neurodevelopmental disorders. So, in the DSM, again, specifically under intellectual disabilities, we have intellectual disability or intellectual developmental disorder, we have global developmental delay, and we have unspecified intellectual disability. So we're going to spend most time talking about the first one, which is bolded, so intellectual developmental disorder, or IDD. So before we dive into what the specific criteria are for IDD, we first need to talk about intelligence. So what do we mean when we're talking about intelligence in this context? How do we measure it? And how does this apply to diagnosing someone with an intellectual disability? So we first need to recognize that different terms have been used over the course of history. So the term mental retardation was popular in the mid-20th century, and that was to replace offensive terms such as idiot, imbecile, and moron. And so over time, we come up with different terms that typically are to replace more offensive terms, and then there's a cycle of us, or not us directly, but people using those new terms in a derogatory way. And then we come up with new words to replace that other offensive word. So this is kind of how we have the cycle of new terminology coming out, specifically in this area. But where we stand now is that we no longer call it mental retardation. So in the DSM-4, that's what the terminology was, and now with DSM-5, which came out in 2013, we use the term intellectual disability. So if you hear words like mental retardation in prior literature, that would be akin to intellectual disability today. So between DSM-4 and DSM-5, not only did we use different terminology, so like I said, mental retardation was more commonly used. In DSM-4, the specific class of disorders were called pervasive developmental disorders, and now we use intellectual disability. But beyond just terminology differences, the way that we also assessed or cared about IQ, or the extent to which IQ mattered, differed. So with DSM-4, there was a specific minimum IQ score for a diagnosis of IDD, or again, back then, pervasive developmental disorder. So specifically, if an individual scored 2 standard deviations below the mean, or had a standard score less than 70, and they had impairments in general mental abilities that impact their functioning, then that individual likely would be diagnosed with pervasive developmental disorder. So when we're talking about standard deviations and what it means to be 2 standard deviations below the mean, what we're referring to is the normal bell curve. So if you look on the right-hand side, this is an example of what a normal distribution looks like. So the idea with a normal distribution is that the general population falls within this continuum, or on this bell curve. So the majority of people are going to fall within the section in the middle where the peak is, and you get statistically fewer and fewer people falling at the tail ends on either side. So remember from our assessment chapter and talking about cognitive testing, IQ has a mean score of 100. So here is 100 in the middle, and with this particular measure, I think we use the WISC, we have 100 to 115 in one direction and 100 down to 85 in the other direction. So with the WISC or any other Wechsler cognitive testing, again, your mean score is 100, and then your standard deviation is typically 15. So one standard deviation is either between 85 through 115. That's where most people would fall along the distribution. If you are 2 standard deviations below the mean, so 2 standard deviations below means we should look on the left side of the bell curve. That tells me that you are at that 70, which is where that red line is, and that's kind of that marker that we're looking for when we're talking about IDD. So if a person falls at this red line, the 70 or below, so they move in the direction of that 55 where it says 0.1%, that signifies pretty significant deficits in cognitive functioning in terms of intelligence. So back then with DSM-4, one of the criteria was that if an individual had an IQ score at 70 or below, that signaled to us that they would meet criteria. With DSM-5 and current approaches, we no longer have this specific cutoff as a hard rule. So, as it says here, we abandoned the specific IQ score requirements, but we still retain this general recommendation of 2 standard deviations below the mean as signifying that there's possible intellectual disability. However, now there's more emphasis on adaptive functioning. So it's not just about intelligence. We also care about what does your functioning look like? How impaired is your life? What domains are impacted by lower intelligence? So how well can an individual independently perform common tasks and skills? And this includes things in the domains of communication, daily living skills, and socialization. So we already talked about what it means to earn a score of 70 or below on an IQ test along a normal distribution. But we haven't talked about the specific conceptualizations of what intelligence is. So there's different perspectives, but there are 2 primary ones. So our traditional psychometric approach examines the products of intellectual or cognitive abilities. So it really focuses on individual differences in intellectual functioning and looks at the distinct underlying abilities that might explain these differences. And they typically look at general ability or G factor and specific abilities. And that can be things like motor and verbal ability, perceptual reasoning, processing speed, working memory. So there's this idea that you have this overarching, broader general ability and then specific cognitive abilities that tap into different cognitive functions. So the way that we measure intelligence from this conceptualization is by administering tasks, and these tasks will tap into general and specific abilities and seeing how people perform. On the other hand, we have this information processing approach, which is really popular among cognitive psychologists, and it's also, I think, a newer approach, or not aligned with the traditional psychometric approach. And this focuses less on individual differences of cognitive abilities, but rather looks at the processes involved in the abilities. So instead of just looking at the general ability or specific abilities, the information processing approach really is looking at the processes by which we perceive things like sensory stimuli, store information, and manipulate information. So it's not so much about general and specific abilities, but rather how do we process information that then might manifest in how we show or demonstrate specific abilities or general abilities. And again, the way we would measure this is by looking at how well a person performs on processing tasks rather than very specific tasks meant to tap into general or specific abilities. So this is from your book, but this just highlights different ways that people have conceptualized and measured intelligence. So at one point we used chronological age, just how old are you in terms of years. We also had the concept of mental age. So the mental age is the age score that corresponds to the chronological age of children whose performance equals, or performance the examinee equals. We also had IQ, but from a ratio standpoint, so where we were looking at the ratio of mental age to chronological age, and then that ratio was multiplied by 100 just to avoid having decimals. And then we also have the IQ deviation perspective, where we have a standard score that's derived from statistical procedures, and this is specifically what we're talking about now. So this is what is aligned with the idea of being 2 standard deviations below. So we're, again, more aligned with this last approach or last measure. In terms of the stability of intelligence tests, IQ scores are thought to be relatively stable. So, what that means is that if you take an intelligence test, your score is not likely to significantly and drastically increase or decrease, provided that there's no like traumatic brain injury or anything like that that would cause a severe decline in your cognitive functioning. So, that's not to say you're going to test the exact same way and receive the exact same IQ score if you were to do it over multiple occasions. But in general, because your IQ is thought to be a relatively stable construct, you're not going to vary a whole bunch in terms of where you fall on the distribution and what classification you fall under in terms of like average functioning, high average functioning, superior, very superior, or any of the things towards the other end of the distribution. So again, IQ scores are relatively stable in the absence of any kind of severe cognitive decline. Now, if you were in, let's say, an accident and you had a traumatic brain injury, or there's some other pretty major cognitive decline in your cognitive decline, then that would be a case where you are probably going to see a drastic change in IQ, and that's because of some direct impact on your cognitive functioning. But in the absence of that, your scores are relatively stable. Now, in terms of validity of intelligence tests, there are a whole host of things that should be considered. So for one, when we talk about normal distribution and we talk about where people fall on that, we aren't just picking a number and saying you fall here in the middle of the curve. So with IQ testing, and I can give you the example of the Wechsler test, so things like the WAIS, the WISC, the WASI, the way that we score that is we look at your performance on all the different subtests. Each of the subtests fall into a larger domain, and you have a raw score for each of those, or your performance on each of these subtests, and then it's converted into a standard score. And the way that they're converted is by using norms based on your age and gender or biological sex. So each of these IQ tests has a huge set of norms based on age and sex that is used when we're converting from raw score to these standard scores. So that's how we get you from raw to a standard score to be able to put you on that normal distribution. So when we're relying on norms in order to make these statistical comparisons, when we construct new test norms, performance in IQ tests tends to drop several points on average. And that's for both typical children and people who fall in the disability range, so people with lower IQ. And so because of this, when you have lower scores on IQ tests in general, then we also might see higher rates of diagnosing intellectual disability because of how there's a shift in these test norms. So that's one potential reason why we might see generationally some differences in diagnosis when different tests are used. There's also the issue of cultural bias, so different groups perform differently in the IQ, when we administer IQ tests. Poor generalizability to problem solving in the real world, and there's also the phenomenon of the Flynn effect. And so the Flynn effect is just a finding that IQ scores in populations seem to systematically improve over time. And that's interesting because it's not necessarily reflecting the fact that people over time are getting smarter or having higher intelligence, but it speaks more to some of the test material or the validity of the actual test. So those are some of the issues to think about when we talk about the validity of intelligence tests. But nonetheless, we know that intelligence tests are an important tool, but we need to remain cautious in how we are interpreting these tests and making sure that we're not making blanket assumptions about people who score one way or another on an IQ test. So especially when we're considering the IQ criterion for disability, we know that it's not sufficient to just look at IQ. We also need to look at impairment and how this individual is functioning in different aspects of their lives. So after intelligence, we also have to look at adaptive functioning. So adaptive functioning or adaptive behavior is what people do to take care of themselves and to relate to others in daily living. So when we are looking at people with intellectual disability, or where we think that they have intellectual disability, we're also concerned with the failure to adapt socially to one's environment. So a lack of adaptive functioning or deficits in adaptive functioning. And so this includes deficits in adaptive behavior in the conceptual, social, and practical domains. So the conceptual domain is related to things like memory, language, reading and writing, reasoning, problem solving, time, numbers, and concepts. The social domain of adaptive behavior has to do with things like awareness of others' thoughts and feelings, interpersonal skills, social responsibility, self-esteem, being gullible, rule following, avoiding being victimized, social problem solving, and friendship abilities. And then practical adaptive behavior has to do with things like activities and personal care of daily living, which includes things like bathing, making meals, getting dressed. And it can also include things like using money, things like safety, healthcare, having routines, using the phone, and occupational skills. So there are different levels and areas within adaptive behavior that we are interested in looking at whether there are deficits in for people with intellectual disability. And again, this is true for all disorders when we're talking about childhood and adolescent mental health problems, but especially with intellectual disabilities, we have to take developmental level into account. So functioning in each of those domains that I just talked about, the conceptual, social, and practical adaptive behaviors, those all vary at each developmental level. So we have to be considerate of where this individual lies in terms of the specific developmental phase they're in, and whether any of the deficits they're exhibiting in these areas seem to track with where they are developmentally or not. So here is an example, this is from your textbook, of the definition of functioning according to severity of intellectual disability and adaptive functioning domains. So when we talk about mild severity of intellectual disability, within the conceptual adaptive behavior domain, we might see things like no obvious early conceptual differences, difficulties in learning core skill subjects, difficulties in executive functioning skills. In the social domain, we might see things like developing social and communication skills, but having more concrete or being more concrete or immature than expected. They might also be at risk for being manipulated by others, so that's being gullible. And then within the practical domain for mild severity, we might see things like the individual functions age appropriately in personal care, but they might need extra assistance in daily living tasks. Within the moderate, we might see delays in language and pre-academic skills within the conceptual domain. Within social, you might see communication skills have been developed, but they're much less complex than their peers. And then within the practical domain, you might see that the individual can care for age-appropriate personal needs, but with extended period of teaching and time. I won't talk about these, but these are, again, the next part of the table. So this is what some examples of what severe intellectual disability descriptively might look like in terms of conceptual, social, and practical adaptive behavior domains, as well as the profound severity level. All right, so now that we've talked about intellectual disabilities broadly, and we've talked a little bit about intelligence quotients and the stability and validity of intelligence tests, and why it matters to also look at adaptive functioning, which we learned has different subdomains of daily living skills that we need to be thinking about. Now we can talk about actual intellectual developmental disorder as a diagnosis within the DSM. And remember, there are, I think, 3 or 4 diagnoses that fall within the intellectual disabilities section of the DSM, but we are only going to focus on this first one. So, intellectual developmental disorder or intellectual disability is a disorder with onset during the developmental period that includes both intellectual, so that's what we talked about with intelligence, and adaptive functioning deficits in conceptual, social, and practical domains. And that's the second thing we just talked about. The following 3 criteria must be met. So deficits in intellectual functions, deficits in adaptive functioning, and onset during the developmental period. And so we typically see it during childhood, but we can see it during adolescence as well. And then we specify the current severity. So when we talk about the severity, we have mild, moderate, severe, and profound, just like we saw on the previous table. But what that might look like in terms of adaptive skills with respect to DSM-5 criteria is that within the mild severity category, we might see an individual who can live independently with minimal levels of support. At the moderate level, we might see someone where independent living can be achieved, but with moderate levels of support. In the severe range, we might see an individual that requires daily assistance with self-care activities and safety supervision. And then at the profound intellectual disability severity level, we have someone who would require 24-hour care, so really unable to take care of themselves. So again, just as a reminder, prior to 2013, with previous iterations of the DSM, we assigned intellectual disability severity based on IQ scores. So remember, we talked about DSM-4, really strictly using that 2 standard deviation rule. And now with DSM-5, which was published in 2013, we now conceptualize both intelligence and adaptive functioning as the 2 important criterion, and therefore levels of severity are going to be based on adaptive functioning, not IQ. So we'll quickly talk now about the etiology of intellectual disabilities, but we won't spend a whole lot of time, so I encourage you to read the textbook. I think there's a little bit more information than the slides. But in general, we know that there are many different causes and correlates of intellectual disability, and some of those causes are known and some are not. But generally, the consensus is that intellectual disabilities are caused by abnormal brain development or brain injury resulting from genetic and or environmental causes. So there are genetic syndromes that are associated with intellectual disabilities, and these different genetic syndromes have different genetic mechanisms that underlie each of the disorders and describe some of the cognitive features. So that includes things like Down syndrome, Fragile X syndrome, Tay-Sachs disease, phenylketonuria, and Prader-Willi syndrome. So again, with each one of these syndromes, they each tend to be associated with a particular physical, cognitive, and behavioral phenotype that we see with intellectual disabilities. So in the first picture on the top right, we have the extra copy of chromosome 21, which is what we see in Down syndrome. And in the second image, we also have an example of what the chromosome looks like for Fragile X syndrome. So you can tell it's a fragile section of the X chromosome. And then here's just a quick video of Prader-Willi syndrome. I think this one's a quick one and interesting if you are not familiar with this particular syndrome. So I would take a look if you have the time. So moving on to environmental etiological factors, we know that this includes things like birth complications, like hypoxia, fetal alcohol spectrum disorders, or fetal alcohol syndrome. So again, that's caused by exposure to alcohol in utero, and it's the most common of potentially preventable conditions that are associated with birth complications and neurodevelopmental issues. Among other environmental etiological factors, we know things like exposure to toxic substances such as lead, mercury, and arsenic are some risk factors. And then also inadequate intellectual stimulation is also thought to potentially hinder early brain development. I think this table is a nice synthesis of what timing looks like and different categories of risk and etiology related to intellectual disability that might be particularly salient given that timing. So whether the individual is in the prenatal stage, perinatal, or postnatal. Okay, so moving now on to prevalence. So we know that the rates among children have recently fallen from 3% to 1%. So in general, we already see pretty low prevalence rates, but it seems that recently it's been dropping. And this fluctuation in prevalence likely reflects shifts in diagnostic criteria for intellectual disorders, differential diagnosis, or there being services available to support adaptive functioning of individuals with intellectual impairment. So it's not necessarily that we are seeing less of intellectual disabilities exist, but it might be that it's really due to changes in diagnostic criteria where maybe more people are being diagnosed with something else that was diagnosed for a differential reason, or we're seeing support services where adaptive functioning is improving, and so now that criterion is no longer met for intellectual disability. So those are a few reasons why we might see prevalence rates drop. In terms of what type of prevalence rates we see at different developmental stages, so we tend to see lower rates prior to school age, and then increased rates as more mild cases get diagnosed, and then we see rates fall in adolescence and then decline further in adulthood. In terms of gender, we see higher rates among males than females, and males in particular are at greater risk for genetic syndromes associated with intellectual disability, so things like Fragile X syndrome. And then we also see higher rates among lower socioeconomic groups, and that might be due to psychosocial disadvantages like increased risk for exposure to toxins, illness, and injury. So in terms of the developmental course and progression of intellectual disabilities, we know that intellectual disabilities are lifelong, but the differences in the course and outcome of those intellectual disabilities really is influenced by the severity of the disorder and the particular cause of the disorder, and then whether or not there are existing risk and protective factors that play a role. In terms of intelligence and the rate of intellectual development, we tend to see that children who are typically developing have intellectual development that really occurs gradually over time throughout childhood and adolescence. But in contrast, in children with intellectual disabilities, we see that development is slower than usual, but that the rate of growth is fairly steady. In terms of sequence of intellectual growth or ordering of intellectual growth, we see that children with intellectual disabilities typically do progress through the same cognitive stages as children who are typically developing, but they don't necessarily, or they do so more slowly, and then they ultimately don't progress as far. So what we mean by the Piagetian stages are the cognitive stages of development. So things like the sensory motor stage, where we talk about object permanence, and then we know that they gradually pass through that and go through the pre-operational stage, the operational, things like that. All right, so your textbook has a nice section on what family accommodation looks like for individuals with intellectual disability. So I'm not going to cover that in the lecture, but I think that that's a good section to read, so please look at that. And then same thing with intervention. I think it's important to review this section in the text since I'm not covering it in the lecture. Okay, so that was our intellectual disabilities section, and remember we spent the most time talking about the section broadly in terms of what we mean by intelligence, what do we use when we're testing intelligence, and then ultimately when we're talking about diagnoses, we spent the most time talking about intellectual developmental disorder. So now we'll move on to autism spectrum disorder, or ASD. So here we have our DSM-5 title, so autism spectrum disorder. And now we'll talk a little bit more about some of the specific changes that we saw between DSM versions in terms of how we conceptualize autism and what that ultimately meant for the specific diagnoses that we were seeing in the DSM. So there have been major changes between DSM-4 and DSM-5, which we are currently on. And one of the biggest shifts was from a categorical system for understanding what autism is to a now more continuous measure. And so where we are now in DSM-5 is that we view autism as a disorder along a spectrum. And if you remember what we talked about towards the beginning of the semester is that in general, within the field of clinical psychology and in looking at all the research that has been done, at least in the last decade and a half, we know that in general, psychopathology is really best understood as a continuous measure. So again, psychopathology is a dimensional, continuous measure, and it's much more representative and reflective to think about how people can vary along this spectrum of functioning or dysfunction, and that also explains why we have so much heterogeneity in what people with the same classification of disorders looks like between one another. So autism was one example of one of the first classifications of disorders within the DSM that really took this dimensional model and actually proposed it and made it happen in the DSM. So this is actually a really nice example of where, in general, we want the field to be and what we would really like to see be reflected in the DSM for all the other classifications of diagnoses. So when we are talking about autism being on a continuum, we now have autism spectrum disorder, whereas in the DSM-4, we were still using a categorical approach where we said you either have it or you don't. It's not on a continuum. And so when we were using that model, we actually had a section called pervasive developmental disorders. And within that, we had autistic disorder, Asperger's disorder, pervasive developmental disorder, not otherwise specified, Rett disorder, and childhood disintegrative disorder. So autism was not just one classification or one disorder in and of itself. You had autistic disorder, and then you had Asperger's disorder, which captured more of these social impairments. So again, what we have now is something that really falls along a continuum, and now we don't break it up into these 5 different categories. Now we have autism along a spectrum, and the one diagnosis in the DSM is ASD. And any previous disorders would theoretically be subsumed under this autism spectrum, because again, remember, we see it along a spectrum. So what we would see in Asperger's disorder would be subsumed or captured still by this new category of autism spectrum. Same thing with autistic disorder. The other thing I want to point out is that if you remember last week when we were covering communication disorders, I talked about how social pragmatic communication, which is in one of the communication disorders diagnoses, is different than autism, although there tends to be a lot of diagnostic overlap. And so here is that reminder again that they are 2 distinct separate disorders, and what really sets apart social pragmatic disorder from autism is the idea that with autism, there's also this presence of repetitive or restricted patterns of behavior, interests, or activities. So we now have this very clear distinction that we need to make between the social pragmatic communication disorder versus this broader autism spectrum label. Also, before we move further, I just want to comment that I actually just realized I misspoke when we were talking about intellectual disabilities. I think when I was saying that from DSM-4 to DSM-5, where we were seeing different terminology being used, whereas with DSM-4, the term mental retardation was used, and now in DSM-5, we use the term intellectual disability. I think I may have mistakenly said pervasive developmental disorder was the larger umbrella section within the DSM-4 that mental retardation was housed under. That is actually not true. So pervasive developmental disorders in DSM-4 was specific to what we would now classify as autism spectrum disorder. So the slide I just showed you is still correct. That's all related to autism. I just want to point out that it's incorrect that what I had said before about intellectual disabilities previously being under the label of pervasive developmental. That is not the case. And back then in DSM-4, it was just mental retardation was its own disorder as a standalone. And then you had this additional other set of disorders within the pervasive developmental, which again is more of the autism-y diagnoses that we would look at today. Okay, so now we can move on. So again, going back to why is it that, we just now have only one DSM-5 category for autism, which is autism spectrum disorder? Why is it that we collapsed those 5 that fell under pervasive developmental disorder now into one DSM label? So again, commenting on this categorical versus continuous debate, one reason why we collapsed it into one category is that research supports the dimensional system of diagnosis. So again, psychopathology is best understood along a continuum. And so autism falls within that, right? So psychopathology is broad, autism is one cluster of symptoms and etiological factors that cluster together that shows us that here's an example of when a continuous approach is better than a categorical one. So again, one reason why we collapsed it for this particular disorder is because research demonstrated stronger validity and reliability when we used this dimensional model instead of the broken up categories. The other thing is that there were many shared characteristics between those 5 disorders that were housed under pervasive developmental disorder. So Rett disorder, Asperger's disorder, autistic disorder, they all looked somewhat similar, and so it was not useful to have so much overlap when we can just have an autism spectrum label, and we can understand that everything lies along a continuum, and it's much less stigmatizing to be able to say that people can fluctuate up and down this continuum than than slapping on 5 different labels. I think the other thing your textbook might note is that although we use one category and one label now, when we use the DSM, which is autism or ASD, you still might see the term Asperger's being used, particularly in community settings. So just be aware that if you hear Asperger's being used, really what that means is autism in terms of the terminology we would use in the research and in the field nowadays. I will let you guys watch this video on your own, but this is just I think 1 to 2 minute video from the APA about what autism looks like in terms of the diagnostic criteria, and we actually will break down some of the specific components in the next couple slides. So the first component when we are looking at autism spectrum disorder is impairments in social communication and interactions. So this is one of 2 core features of ASD. So what this looks like in young children is a decreased social interest. So you might see kids who are less likely to respond to their name. We might see children who are more likely to show unusual responses to sensory stimuli, so they might have an aversion to being touched. We might see decreased eye contact, or kids who exhibit sort of this empty glaze over their face. They might fail to respond with emotional expression to you, and there might be deficits in joint attention interactions. In general, we see a lack of understanding of social cues and inappropriate social interactions, and that can look like aloofness, acting disinterested, seeing a lack of reciprocity in terms of the social cues, what's shared in an interaction, and displays of empathy. You also might see difficulty navigating the subtleties of social interaction, so things like sarcasm or really subtle visual cues that someone might make, or nonverbal behaviors that they'll demonstrate. And then things like having trouble forming friendships and maintaining them over time. Along with deficits in communication, you also might see some echolalia or pronoun reversal. So you might see deficits in both verbal communication or nonverbal communication. The second core component that we consider in autism is the presence of restricted repetitive behaviors, interests, or activities, or RRBs. So these are repetitive sensorimotor behaviors. In young children, we typically see a lot of these type of behaviors. So we might see things like walking on toes, kind of twirling, rocking back and forth, hand flapping. You might see the repetitive use of objects, so things like lining up objects or having like a certain number of objects or toys. You also might see self-injurious behavior, so that looks like sometimes banging their head against a wall, crying, things like that. The other thing on top of repetitive sensorimotor behaviors is an insistence on sameness. And this is a little bit more common in older children with ASD versus the repetitive behaviors, but that's not to say that you don't see either one in either age range. So with insistence on sameness, you tend to see this preoccupation with aspects of the environment. So in terms of the routines, insistence on following a ritual, feeling really uncomfortable or in great distress when routines or your environment changes. And you also might see that these kids become obsessive or really absorbed into their activities or interests. All right, so here are the diagnostic criteria for ASD. So criterion A has to do with that social communication deficit that we covered. So criterion A tells us that there are persistent deficits in social communication and social interaction across multiple contexts as manifested by all of the following. Either currently or by a history. So that would include like retroactive reports by the parents who are reflecting on the child's history and the behaviors that they just demonstrated in early childhood. So all three of these things need to be present. Deficits in social emotional reciprocity, deficits in non-verbal communication, and deficits in developing, maintaining, and understanding relationships. Criterion B has to do with the RRBs. So this is restricted repetitive behaviors or patterns of behavior, interests, or activities as manifested by at least two of the following. And again, it can either be something that is currently being reported or has been reported in the past when reflecting in prior history. So you see stereotyped or repetitive motor movements, insistence on sameness, highly restricted fixated interests that are abnormal in intensity or focus, and hyper or hypo reactivity to sensory input or unusual interest in sensory aspects. Criterion C tells us that these symptoms must be present in the early developmental period, but again, note that these may not actually fully become apparent until the child gets older and more social demands are placed on the child, and we start to see that exceeds what the capabilities or the capacity of a child actually is. Criterion D is that symptoms cause clinically significant impairment in a range of areas of functioning, and then again we have criterion E, as we do in all the other ones, where these disturbances should not be better explained by some other disorder. So we'll spend some time now talking about the etiology of autism. So heritability rates are quite high, and they range from about 64 to 91%. We know that ASD risk is highly polygenic, which means that there are many genes involved in the risk for ASD. So there's not one single gene in particular that is responsible for autism. And that's the case for many of the other disorders that we've been talking about. When we talk about the neurobiological factors, same thing applies where there's not one single neurobiological anomaly that has been identified in people with autism. But in general, we do tend to see greater brain and head size, higher incidence of seizures, and structural brain abnormalities. As far as environmental risk factors, these include things like advanced paternal and maternal age, so basically older parents, maternal exposure to toxic chemicals, maternal obesity or gestational diabetes, maternal metabolic factors, and then maternal immune reactions during pregnancy. It's also very common for there to be prenatal and birth complications among people with autism, but this is unlikely to be causal, but rather associated with some of the typical features that we see in people with autism. So you'll notice in the previous 2 slides that there is no mention of immunizations or vaccines, and that's because vaccines do not cause autism. So again, I want to reiterate, vaccines do not cause autism. The myth that vaccines cause autism really was propelled by one article that was published in The Lancet in 1998 by a doctor who tried to draw causal inferences and draw links between the MMR vaccine and pervasive developmental disability, which, remember, was the term used back then for autism. So there were many methodological and substantive flaws with this person's research, and in fact, that paper was actually retracted from the journal, and that author, which was a medical doctor, lost his medical license. So it's actually a huge deal. So when you are submitting your work to an empirical journal, you are submitting it for peer review. And this is a really rigorous process that gets, it's a rigorous process because you have people with expertise reviewing your paper and commenting on gaps in the literature that you haven't filled, anything that they want to point out in your methodological design that needs to be improved. And once you've addressed those things, if they see fit, then the paper gets accepted in the journal. So the fact that this paper was retracted is a huge deal because typically it's pretty unheard of or very big reasons why you would retract a paper. It's usually that the paper was so damning, was so harmful, there was ill intention in the design, it was intended to harm, things like that. So the fact that this was retracted and he later lost his medical license points to how big of a deal this was. So recent research, and since then, research looking into this to debunk his myth that vaccines cause autism have in fact shown that there's no connection between any vaccine and the risk for autism. So here's a screenshot, if you're interested, of a recent paper that did a review on the history of how this myth of vaccine causing autism came about, and some of the more recent research that shows that this is actually not true. I find that this particular journal and this type of review, so under the annual reviews journal, they have a lot of really thorough but understandable and digestible papers, so this is a good one if you're interested in reading more. Besides the vaccine myth, there's also a myth that inadequate parenting, or something called refrigerator parenting, is a cause of autism. And so just want to note that that's another myth that has been debunked. Looking at prevalence rates of autism, we know that it tends to be more common in boys than girls. There are many reasons for this. It might be that this is actually representative of what's out there in the population, but it also might be related to changes in diagnostic criteria where boys are getting diagnosed at higher rates than girls. There might be more awareness with all the improvements in how we're conceptualizing autism and kind of the knowledge out there about it in the mainstream community. Also, the fact that COVID-19 impeded earlier diagnosis intervention when we had the lockdown orders. So that might be a reason why we're seeing higher rates of diagnosis post-COVID. And then there are also things like incentives for diagnosis, which lead to inaccurate diagnosis. So those are some reasons that might be responsible for the higher prevalence rates. But nonetheless, we do see that it's more common in boys than girls, and we see a ratio of generally 3-to-1 worldwide. So boys are being diagnosed at about 3 times more likely of a rate than girls. In terms of the developmental course of the symptoms and what onset looks like for people with autism, we know that there are 3 common patterns of symptom onset. So the first pattern is the most common. It occurs in most children, and this is where you see abnormalities in the first year of life. So it's pretty obvious within the first year. You also have another pattern, and that's number 2, where you have basically typical or near typical development, and then that is followed by some sort of skill regression. So you see deficits or kind of reverting backwards in terms of a child's language abilities, their social skills, or their motor skills. The third pattern of onset is where you kind of see problems from the get-go. So you see mild delays until about age 2, and then you see either gradual or abrupt developmental arrest or plateau. While behavioral symptoms may not emerge until later in childhood, we do know that autism is present from early in development, and in fact, it can be reliably diagnosed by age 2. So even though we may not see behavioral symptoms before age 2, or just generally not until a child is a little bit older, there might still be indicators that autism is still present, and in fact, we know that neurodevelopmentally, those indicators are there already at an early age. And then in terms of just the trajectory and course of the lifespan of someone with autism, despite modest improvements over time in their symptoms, we know that symptoms generally persist into adulthood for most people with autism. As far as treatment for autism, there's not a single cure for autism. So it's not a single pill that you can take that'll just cure someone of autism. So it's not that we aim to get rid of autism. Treatment instead really focuses on improving their functional outcomes. So working on those adaptive functioning skills, really working to enhance some of those deficits in social communication, working to build some flexibility and distress tolerance for those restricted, repetitive patterns of behaviors and interests. So that's really what we're focusing on in treatment for autism. Most treatments are behaviorally based, and these are the ones that are considered the most empirically supported interventions for autism. And one example is applied behavior analysis, or ABA, which was first developed by Lovas and used principles of operant conditioning, including things like punishment. One thing to note is that this has a lot of evidence base, but there's still some controversy about ABA, and in particular, the use of punishment, and there's also some debate about whether or not something like ABA is kind of changing people's individuality and kind of punishing them for some of these individual quirks. So there's some controversy about it, but nonetheless, ABA is an evidence-based treatment, and when it's done correctly and ethically, you tend to hear a lot of families who feel that they've immensely benefited from a child having ABA services. So that's just one example of an intervention, but your textbook has like 5 pages worth of interventions, so I would read that as well. Okay, so I thought it'd be interesting to use a quick case study and let you think a little bit about whether or not you think this person meets any of the diagnostic criteria for autism spectrum disorder. So here we have JR, and JR is a 2.5-year-old multiracial boy. He's the only child in his family. He is currently nonverbal and has been unable to successfully toilet train. JR rarely makes eye contact and does not respond to his name. He is extremely averse to certain tastes and textures and will currently only eat crackers, pasta, and Cheerios. Since he was born, JR has been sleeping in the same bed as his parents. He must be rocked to sleep every night, and he wakes up several times during the night. When his parents need to make any changes to his routine, he gets very upset and cries. JR also gets very upset when he sees other children crying, laughing, or making loud noises. JR loves the alphabet and will spend hours putting his alphabet set in a row. He gets very upset if anyone tries to move his toys and does not seem interested in playing with others. JR is extremely affectionate with others, but does not demonstrate any stranger danger and will often get uncomfortably close to others. Finally, when he's excited, he will roll back and forth on a couch or other object. So here's our case study. And take a second just to think about if you think that any of the indicators here for autism can be mapped on, or if there are any indicators within this vignette that map onto the criteria for autism. So hopefully you paused it before starting this slide. But yeah, basically we do see that JR meets several criteria for autism. So we know that JR is 2.5. We hear that he's nonverbal. We know that he rarely makes eye contact and he isn't responding to his name. So those things kind of signal to me the eye contact, not responding to his name. That maps into the social communication deficits. He's extremely averse to certain textures or tastes. So that seems like that falls within the restricted repetitive patterns of behavior or interests. And he only eats crackers, pasta, and Cheerios, so same thing, that would fall under the RRB section. Seems like he has trouble sleeping, so that seems like, he is 2.5, so it's not uncommon, but by this point it seems that it's really impairing. When his parents need to make any changes to his routine, he gets really upset and cries, so that shows, again, distress tolerance is quite low. And suggests some insistence on sameness or some inability to be flexible with routines. He gets upset when he sees other children crying, laughing, or making loud noises. So this might be some hyper-reactivity to noises. We see that he loves the alphabet and spends hours putting his alphabet set in a row. So this seems like a restricted interest. And the fact that does he line them up? No. Yeah, it says that he sets them in a row, so that also would fall under the restricted repetitive behaviors clause. He gets upset if anyone tries to move his toys, so that's also potential restricted RRB. What else? Does not seem interested in playing with others, so that goes back to the social communication and interaction deficits. Extremely affectionate, so he doesn't show any stranger danger. That's also another deficit in social interaction. And when he's excited, he rolls back and forth. So that's some of that stimming, which is also under RRBs. So overall, yes, it looks like he meets all of the criteria for criterion A. Same thing for criterion B. Looks like, yes, criterion C is met because he is 2.5, and we're seeing these symptoms pretty early on. They do seem to cause clinically significant impairment, and while we don't know for certain because he hasn't done intellectual testing, let's just assume for argument's sake that criterion E is likely satisfied. All right, so hopefully that was helpful just to think a little bit about autism and what that might look like in a clinical setting or a clinical case. So now we'll transition to talking about schizophrenia. And the reason why we're talking about schizophrenia is because, number one, it's in your book, but theoretically, the reason why schizophrenia is typically discussed in tandem with autism or pretty soon after is because there are some theoretical roots that both autism and schizophrenia seem to have. So looking at this table of contents, in the DSM, so we're no longer in the neurodevelopmental disorders section, so we have finished with that. When we're talking about schizophrenia, we are actually talking about a different class of disorders, so that's the schizophrenia spectrum and other psychotic disorders, and that includes this list of diagnoses. So what we're going to be covering today briefly is schizophrenia in particular. So in the broader umbrella of schizophrenia spectrum and psychotic disorders, we know that the disorders housed within this section is organized a gradient of psychopathology. So typically we see increasing levels of severity. So at the very top, which is the lowest level of severity, we see schizotypal personality disorder, and that kind of goes, increases in intensity, and you can see that we'll be talking about schizophrenia, which falls a little bit higher along the severity continuum. So why talk about schizophrenia in youth? Well, autism and schizophrenia in youth are distinct disorders, but they share a rich history. So for many years, childhood schizophrenia was applied to heterogeneous groups of children with certain impairments, and that included children who actually didn't have schizophrenia but instead had some sort of intellectual disability or had autism. And so now we know that these are distinct disorders, and we can appropriately say that someone is actually on the autism spectrum or has some sort of intellectual disability, and we know that that is different from schizophrenia. But it's important to still think about some of the theoretical roots that are shared, and to know that, because of this shared history, we actually do see some symptom overlap between people with schizophrenia and people with autism and intellectual disabilities. So again, they're distinct disorders, but there's some overlap that's important to talk about, because it's not uncommon that you see people with autism also demonstrating more psychotic symptoms that might look like schizophrenia. So again, separate disorders, and in fact, when we look at schizophrenia, we know that the essential features of the disorder hold across age. So it doesn't matter that you're an adult or a child, we still see some of those hallmark features. So there's two types of onset when we're talking about schizophrenia in youth. So we have childhood onset and we have adolescent onset. When onset occurs in either childhood or adolescence, there must be failure to reach expected levels of interpersonal, academic, or occupational achievement. So that has to be there in order for a diagnosis of either childhood onset or adolescent onset to be given. So childhood onset really refers to the onset before age 13, and adolescent is afterwards. And in fact, we actually tend to think that adolescent schizophrenia looks a lot like adult onset schizophrenia. Diagnosis in youth is reasonably reliable, especially in inpatient psych settings. But diagnosis before age 13, so that childhood onset, is pretty rare. And when we're thinking about diagnosis, the symptoms must be distinguished from typical development, and it needs to be put in the context of the child's developmental level. So we've been seeing that across the board, where, again, paying attention to the developmental phase is really important, paying attention to context is really important. But again, it's really, really important here because we don't want to say someone has schizophrenia if, this child has an imaginary friend and they're 4 and they've had it for only a month or so. That's really different than a child who persistently has hallucinations, delusions, and it's been ongoing. Here are the diagnostic criteria for schizophrenia. So we have criterion A, where you need at least 2 or more of the following, and then we have criteria B through F. So the essential features that we said earlier hold across age, which just means that they're present for both youth and adults, is referring to these core symptoms that are outlined in the criterion A section of the DSM for schizophrenia. So this includes things like delusions, hallucinations, disorganized speech, disorganized or catatonic behavior, and negative symptoms. So the first 4 are what we call positive symptoms, and the last one is the negative symptom. So the way that you can remember the difference between the two is that positive symptoms indicate some sort of distortion or excess in normal functioning. So you can remember this because we think excess, there's something added or in excess that makes it positive. And then negative, in contrast, is some sort of lack of normally occurring behaviors. So let's talk a little bit more about positive symptoms. So those are the first 4 that we saw on the previous slide. So when we're talking about delusions, we are talking about erroneous beliefs. These beliefs can be persecutory, somatic, bizarre, or grandiose. So an example of a grandiose delusion would be thinking that you are God. Hallucinations refer to erroneous perceptions, and these perceptions can be auditory, visual, command, or persecutory. So an example of an auditory hallucination is hearing people talking to you that aren't there. A visual hallucination is something like seeing something that's not there, seeing something run across the room when you're in a room by yourself. So things like that. Disorganized speech
is really reflective of a thought disorder. So with disorganized speech, we're really talking about distorted thinking. So we see difficulty organizing thoughts, and we see speech that may be illogical, incoherent, or incomprehensible. And ultimately, the speech is just not understandable, and it doesn't actually convey much information to the other people because of how incoherent it might be. And then the fourth one is grossly disorganized or catatonic behavior. So disorganized, when we're saying grossly disorganized, what we mean is unexpected agitation or aggression, lack of self-care, or inappropriate silliness. With catatonic behavior, we're really talking about motor disturbances. So either really excessive motor reactivity or a lack of motor activity, or even things like really odd, strange body posture that might be really rigid. For youth diagnosis, one thing to note is that we tend to see a lot of emphasis on these positive symptoms, especially hallucinations and delusions. So then we have negative symptoms, and remember, these are symptoms that really mark a lack of normally occurring behaviors. So this can look like having very little emotion or really flat affect, having brief speech that doesn't convey much information, or no initiation or motivation or maintenance of goal-directed actions. I won't spend time talking about the etiology, but this is in your book, so I think this is really important to look at because remember, there's some overlap with autism that I think is covered in the book, but also just for your knowledge, schizophrenia really is a highly heritable disorder, and in fact, that's why I have this second slide, which is an interesting clip of a documentary if you're interested. So this is about 6 out of 12 brothers within the family who all had schizophrenia, and that really speaks to the heritability of this particular disorder. So I think this is really interesting, especially because from what I remember, there's actually a book about this family. I think it's called The Hidden Valley or something like that. Where you find out that the onset of their schizophrenic symptoms was definitely throughout, I think, adolescence or childhood, and you were seeing similarities in the brothers and some differences in terms of the symptom onset and the particular content of their delusions. So in terms of the developmental course of schizophrenia in youth, with childhood onset, we see that the symptoms are likely to be gradual. So it's pretty rare, and only 5% of cases where you see onset is acute. So it happens all of a sudden. When we talk about delusions for children with schizophrenia, these are things that are likely to be simple when they first appear, and then they gradually become more elaborate. Children's hallucinations tend to include animals, toys, and monsters, and again, they're very likely to be simple. And then negative symptoms are pretty unlikely, or you see it less often than the positive symptoms for childhood schizophrenia. The course varies in terms of the trajectory of schizophrenia symptoms, but there are 4 typical phases, and that's the prodromal phase, acute, recuperative/recovery, and the residual phase. As far as adolescent onset, it seems to be less gradual, and it's actually seemingly more similar to adult onset schizophrenia in that there's pretty decent variability in the timing, the severity, and the nature of the early features. And again, the actual symptoms seem to be a lot more similar to those seen in adults. Unsurprisingly, early onset is associated with poor outcomes, and unfortunately, child and adolescent schizophrenia carry a higher than usual risk for premature death. I won't cover intervention, but I encourage you to read these 2 pages in your textbook that does cover intervention for schizophrenia. And then that is it for the lecture. So here is your weekly to-do list. This is the chapter 12 reading and the chapter 13 reading. And then we'll end here with just a reminder of what's happening next week. So next week is week 8. We're covering the feeding/eating and elimination and sleep disorders section. And by the end of next week, so by Sunday, October 13th, your second assignment will be due by 11:59.